Michael Baum. I welcome from the medical affairs and from the Dr. Reddy's, all the speakers and the panelists for this ISP, and looking forward for your a very exciting discussion and from both the Dr. Michael as well as the other speakers and panelists. Over to you, Vidya, for the introduction of Dr. Praveen Chandra.
Thank you so much, Dr. Mushtaba. So it's an honor for Dr. Reddy's to have an esteemed panel of interventional cardiologists amongst us for this first international speaker program. For now, I would like to first introduce Dr. Praveen Chandra, who will be the moderator and the speaker for today's event. He is a Padma Shri and currently the chairman and division of interventional cardiology at Medanta Hospital at Gurgaon. Dr. Chandra is a leading Indian cardiologist and chairman of interventional cardiology at Medanta Medicity, Gurgaon, India. He has been awarded for success and achievement in the field of medicine with Padma Shri in 2016 by the President of India. He is a fellow of the Endovascular Intervention Society of India and the Asia Pacific Society of Interventional Cardiology. Dr. Chandra has been a distinguished faculty member in various international meetings and was the organizer and director of the AMI course held in New Delhi for the year 2005 and 2006. He has published approximately 100 articles, reviews, abstracts in various national and international journals. He has been awarded the prestigious Recognition Award for Success and Achievement in the field of angioplasty in 1998. First time in India, he did percutaneous aortic valve implantation without surgery. He also did the first ever percutaneous mitral valve repair. He was also the first one who used angiojet thrombectomy device, started percutaneous myocardial laser vascularization program in Asia, and the first to use FFR and bioabsorbable stents in India. Dr. Chandra has expertise in every aspect of interventional cardiology and clinical cardiology. And it's an extreme honor for Dr. Reddy's to have him here with us to moderate and lead this scientific discussion. With this, I would like to hand over to Dr. Chandra for context setting and to lead us through the subsequent talks.
Thank you, Vidya. I think it is a pleasure to be here amongst top cardiologists from the country and also Professor Baum from Hamburg. And today's discussion is going to, be around heart failure and new therapies. And Professor Baum is from director from the University of Hamburg, and he is basically a top-level cardiologist from Germany. And he has so many papers written by him, and there are so many things. So it will take a long time. 350 original papers, book chapters, articles, etc. And he is, of course, the member of so many societies and esteemed cardiologist from Germany. So maybe we can start with Dr. Baum now and then subsequently go on one by one. Okay, so we request Dr. Baum to start.
Thank you very much. First of all, I would like to thank the organizers to have invited me to this interesting meeting. So I will go back and discuss with you heart failure, the overview and challenges, in particular with the use of ARNI, some barriers, and also the position in the guidelines. I would like to detail the position in the new European guidelines, which hopefully understands how the position was and why it's so important that it is really a very early treatment which should be introduced rapidly in patients with chronic heart failure. So these are my disclosures. And I would like to make 5 points. First, the principles of recommendations and new trials in the guidelines. I would like to address the principle of the vulnerable patient, which is in some physicians' mind as a barrier to introduce treatments. I would give you an argument to start early and not to wait with the initiation of sacubitril valsartan, but also with the other trials. And I will give you some clinically important data on ARNI, which of course support the early use of it. And then I will summarize what the current recommendations state. So the principles of recommendation in new trials. So the principle of heart failure treatment is neuroendocrine antagonism. And that is a classical one. And you can see here what was the rationale for all the treatments we are doing. So norepinephrine, angiotensin II, and aldosterone are all elevated in patients with heart failure, and the height of the circulating serum concentrations are closely associated to death and heart failure hospitalization. So therefore, during many years, there was, of course, the attempt and many trials to block these mediators, to prove causality of their bad effects, and also to provide therapy. So we have positive trials for RAS inhibitors, beta blockers, and MRAs, indicating that these are really important. And now there are new kids on the block. And the first one, of course, is the SGLT2 inhibitor. The mechanisms are quite unclear. I would just like to mention the data, and these you might call metabomodulators, and they have all shown benefit. I will show you briefly the data. The next one is the ARNI, and the ARNI combines two mechanisms. The first one is inhibiting by the component of valsartan, the neuroendocrine activation, which is among the neuroendocrine antagonists, but also it strengthened another mechanism which is forced, but also on the other hand not working due to a breakdown enzyme called neprilysin. Namely, it also accentuates neuroendocrine protection. So this you might call neuroendocrine modulator. So these are the mainstays of our heart failure treatment. Here you can now see the rationale for neprilysin inhibition and thereby sacubitril valsartan. So in heart failure, pathophysiologically, all the vasoconstrictive mechanism and the maladaptive mechanism are overwhelming, and they are the winner in this game. Angiotensin II produces hypertrophy, vasoconstriction, therefore increased afterload and sodium retention. Among that is the release of aldosterone. And on the other hand side, there are counter-regulatory peptides, which is ANP, BNP, and CNP, among many others, which are not all known. And they provide protection, and they are the losers in the game. And the reason is that there is an enzyme which was called neutral endopeptidase, now neprilysin, and this neprilysin breaks down all the protective peptides into inactive products, therefore they do not work. So what can happen, and the rationale of the development of valsartan and before omapactrilate and also single components who do not work, as well as this combination specifically, is an inhibition of neprilysin, indicating that this, or following the hypothesis, that this would increase the concentration of protective peptides, thereby providing protection to the heart. And this has been shown, and I reported on that in India several times, is a Paradigm HF study, which was a pivotal trial in patients with heart failure and a reduced ejection fraction. And you can see a 20% risk reduction. The effects start early and progresses as time goes by. So now the next point is, what was the thing which gives them a class 1 recommendation? So what you have seen here in this slide is the composite endpoint, which is a combination of cardiovascular death and heart failure hospitalization. But the study was also powered to look independently on those two components. And what you can see with a low, very, very low p-value, both of them are positive in a very similar way, 20 to 21% reduction of these different separated endpoint. So there is not a split effect on two components of the primary composite. It is one homogeneous effect. And therefore, it is very clear that this gets a class 1 recommendation in the guidelines, and this means should definitely be done. So now, how does it work? And can you see that it works? And I show you these data because I'm always impressed by this. So the history of heart failure is progressive remodeling. It can be hypertrophy in patients who have HFpEF, for instance, but also usually, in particular, when there is an ischemic event, it progresses to ventricular dilatation. So the progressive remodeling then causes maybe valve incompetence, and that further contributes to the remodeling processes. And here you can see that the de-remodeling effect, the heart failure drugs, which have been proven today, are not very strong. You can see placebo, so there is a progressive dilatation and increase in ventricular volumes. Ejection fraction is usually not much affected by this in patients with a low-grade heart failure. And you can see sometimes a little bit of calvedilol has a de-remodeling effect, but not of the ACE inhibitor. So here is room for improvement. This is a prove-it trial from Boston, and that shows very clearly that there is a change of ejection fraction, yeah, that there is from baseline after sacubitril/valsartan an increase of ejection fraction. This is the 0 line here, and there is also an end diastolic volume, which is going to decrease. Yeah, here is 0, it goes down, and you can see that it is also left ventricular end systolic volume and atrial volume. They all go down. So this is a very, very straight effect on deremodeling. And you can see that there is also a fair to good correlation to ANP. So you can either do an echo and look at the heart directly, or you can measure one of these biomarkers. So clear evidence that the pump function of the heart gets better. Now here you can see how important that is. When you look at reverse remodeling, you can see patients without an event and with an event. And you can see also that what we are usually treating interventionally, that is mitral valve regurgitation contributing to it, it gets much better after treatment. Yeah, here you can see patients with an event, without an event, and you can see indeed that there is a strong change of these mitral regurgitation. So they all end up in better stages here. So it even can be something in some patients which is a substitute of an intervention. So therefore, here remodeling is occurring with valve treatments, but also with drugs. And so therefore, treatment with medication should be done first. So there is a recommendation to provide full therapy, including sacubitril/valsartan, which is the agent with the strongest effect on deremodeling early in patients, and then wait and reevaluate all the other things for the device therapies. So now what was the principles of the old guidelines? I brought you here the 2008 guidelines and the 2012 guidelines. So the ESC and also the American policy was always follow the trials. And that means there should be a stepwise up titration of drugs to the maximally tolerated dose, if not highest dose approved, and then move to the next drug. And the question here is of whether that takes time. Yeah, you can see that CVIS-3 study has shown that one can give both together beta blockers and ACE inhibitors, so that doesn't matter. But still, there is this up titration and the sequencing of drugs, and that means that we are losing a lot of time before patients are on full treatment. So Pioneer Paragon, of course, shifted this a little bit, adds more drugs, but still postponing treatment might cause events because you are too late to have this in patients. So therefore, that could be an alternative, providing all drugs in one stage. And these were the guidelines, and you can see that this was a committee with a very intensive discussion. And I think these guidelines are extremely important because it really had changed the strategy to treat patients with heart failure. And this is a strategy change. So what the guideline now recommend, and that is exactly the same what the Americans have now published 4 weeks ago, is that a patient has a class 1 indication for diuretics if he is congested and overloaded. On the other hand, there are 4 drugs also to given simultaneously very early and as fast as possible when the patient comes with heart failure. And this is the ACE inhibitor ARNI, it's one group. I will discuss why there is ACE inhibitor first. So this is a political decision. We made a voting in the committee. If there is a naive patient, he should definitely have the ARNI and not the ACE inhibitor first. That was changed from the old guideline. And then at the very same time, and I will tell you how that could work, beta blockers, MRA, and SGLT2 inhibitors should be provided. Then you wait 3 months, and then you come along with the device therapies, including CRT, ICD, or potentially and valve intervention. So these are the new kids on the block with new recommendation. ACE inhibitors had to stay class 1A because they have the evidence in more than one trial to improve cardiovascular death and heart failure hospitalization. And therefore it stays 1A, of course. And then beta blockers, MRA are all class 1, and new is dapagliflozin. And then, of course, sacubitril/valsartan is a 1B recommendation. So in Germany, there is often sometimes a misunderstanding that 1A and 1B means a difference. It does not. The A describes 2 trials, the B describes 1 trial. And the positive effect in paradigm HF was so expressed that there will be never a second outcome trial because it would not be possible to have a control group for ethical reasons. So dapagliflozin, empagliflozin, briefly, 2 trials, DAPA-HF and EMPEROR reduced. You can see a clear effect with 2 agents from the same class. What they have in common is a reduction of cardiovascular death and heart failure hospitalization by 25 to 26%. So you can see that is very similar. And the meta-analysis, by the way, showed no heterogeneity between the 2 drugs. So this is apparently a class effect. Now, sacubitril/valsartan, yeah, so that is here, these recommendations. Sacubitril/valsartan is definitely recommended to be exchanged in every patient who is showing up with an ACE inhibitor or with an ARB because he had maybe some side effects like coughing. So therefore, there should be definitely a replacement with a class 1 recommendation. And said it again, B means how we reach that recommendation. It does not show a value of the recommendation. It just means 1 trial, which is so big that there will never be a second one. The next question, which is different from the previous guideline, is that initiation of sacubitril/valsartan should be done in naive patients. Yeah, there is no outcome trial in naive patients. Therefore, the Europeans are very formal. They say, okay, it's a 2 recommendation, should or could be done. B, because it's a subgroup, and I will tell you why it is, and it is a smaller study, level of evidence B. And we very closely looked into this trial, and this is a Pioneer HF study, which has a design that it looked on patients who have been decompensated and recently recompensated. So you can see this is a trial of about 880 patients. It was not powered for outcomes, but the results are clear concerning unloading of the left ventricle on the left-hand side and concerning the exploratory clinical endpoints, such as heart failure hospitalization, death, implantation of a assist device or transplantation. The results are clear. Sacubitril/valsartan works, and there is no difference of whether patients have a de novo heart failure or acute or chronic decompensation, and coming with that, whether they are pre-treated or not. So therefore, as this is an exact effect, they give the recommendation to start in the naive patients with sacubitril/valsartan, to make that very, very clear. Yeah, the Americans, they are a little bit more relaxed. Yeah, they don't make it so formal. You can see a 1A recommendation here with sacubitril/valsartan. Yeah, the ARNI is recommended to reduce morbidity and mortality, and they just gave him the class 1 recommendation, and they put all into one basket. The Pioneer, the Paradigm study, the subgroup analysis of Paragon, and also some studies who just looked at tolerability and safety. So therefore, the totality of evidence, and that is the key word here, argues in favor of a class 1 recommendation. And the level of evidence is here A, because they also put into consideration other studies and papers. So now physicians are sometimes reluctant to use the drug because they are afraid of side effects. So I will talk about the problem of the vulnerable patient, and I will give you an argument why we should start early. So we just put that together. It's in the ESC Heart Failure Journal. And you can see that the highest mortality is occurring in the hospital, taking into consideration that the stay is very short. The second highest, and that is really the problem here, is in the post-discharge phase, the vulnerable patient. And in the outpatient clinic, where the patient is stable, there is a reasonable low hospitalization rate. And what you can see here, that all the trials, which are really successful, Paradigm, DAPA, EMPEROR, and all these trials have been done in the stable patient. There are some circumstantial evidences from trials like Victoria Soloist. I will not go deep into that. And we have also the Pioneer studies who address the vulnerable phase, the early phase after discharge. And the acute heart failure trials usually are different drugs with very various and most of the time neutral outcomes. So therefore, we have here the problem patient. And the question is of whether we can make patients better in recovering when they get an early treatment, but the phenotype of this patient is very different. This patient is bed-bound. This patient is rather fragile. He has a more expressed sympathetic activation. Neuroendocrine activation is not fully mobilized and is not on full treatments, and then it gets better over time. So here you can see that indeed the death rate, in particular the heart failure death rate, which are here the filled circles, they are extremely high early after discharge from the hospital, in particular in the 30 days. And one of the reasons might be that these patients are not covered by adequate drugs. Now, what about sacubitril valsartan in this set? So this were the studies the guideline committee looked at. And the one is a paradigm study. And on the right-hand side, you can see a secondary analysis from the paradigm, which really was not so much looked at. You can see the positive results on the left-hand side, but on the right-hand side, you can see an extraction of the early phase of treatment after 30 days. And what you can see that the curves visibly separated before 10 days, and the separation of the curves continues as time goes by. And this indicates that treatment initiation is postponed. You lose patients reflected by the area in between the Kaplan-Meier curve, and therefore some of the patients will never reach the benefit because they already died or already go back into the hospital, which of course affect their course on outcome in the later stages. So again, this was directly addressed, and now I come more in detail to this by the Pioneer HF study. Pioneer HF took patients after decompensation, they stabilized them in the hospital, and then they randomized them either to enalapril or sacubitril valsartan. And that was a very tough design because people had to be off an inotrope only for 24 hours. They had to be off an IV vasodilator only for 12 hours, and the treatment was started in the hospital. And the surrogate taken was NT-proBNP as a primary outcome, reflecting the unloading of the ventricle. And then they collected exploratory clinical outcomes as heart failure hospitalization, death, assist device implantation, and cardiovascular death, of course. So here you can see the results. And again, you can see the same as in the early analysis of the Paradigm HF study. Curves separate very early, and they really separated as time goes by. And you imagine here was somewhere here, 2 days before, there was the recompensation. And this results in one of the lowest number needed to treat we have seen in the heart failure field. It was a 46% risk reduction with a number needed to treat from 13. However, it is not as a class 1 recommendation in the European guidelines. However, it was in the American guidelines because it was not powered, as you can see, 880 patients. So it's not a 2,000 or 5,000 men trial. But you can see there is no chance that these curves recross again. And secondly, Paradigm takes over here after a couple of months of randomization. So these are the data you've shown before. There is no difference of whether people were pre-treated or not with an ACE inhibitor, no difference of whether this is acute on chronic, or whether it is a de novo heart failure concerning the unloading of the left ventricle on the left and the serious composite endpoints on the right-hand side. So therefore, it's a clear result. There is not one point which is really disturbing. So therefore, as the results are so clear, the recommendation come together. Now, there were discussions of whether this translates into clinical practice. Some physicians might say, okay, yeah, but this is a trial design and so on. And here you can see that people have indeed re-evaluated that and looked how many patients might be eligible for Pioneer. And here you can see that the majority of them in the overall outpatient clinic, more than 20% are eligible for this population. So we are dealing really with all the patients in the hospital who are going out. Now, the question is it a general phenomenon? So I talk now about sacubitril valsartan, and we have to be self-critically state that we all over the years indeed started treatment very late. I pulled out here all the data from the Emperor reduced trial, DAPA-HF, black, and this lila ones here, violet ones. And you can see the line of neutralities here, but all treatments started very early. You can see 12 days in the Emperor, It was 28 days, the data here in the dapagliflozin trial, but even the SOLVE trial, the Ephesus trial, and some of the beta blocker trials, they started early. And that indeed gives a clear recommendation, and I think this is really groundbreaking, and this really will improve our clinical practice, is the clear recommendation, class 1, with a C, of course, because there is no dedicated trial, to start in the hospital before discharge with all medications. The other thing also important, the patient should be completely rehydrated, so it should be not overloaded, and it should be seen outside the hospital, that you can recognize of whether there is a problem, and also to increase the doses, as we expect that in the hospital there will be quite low. So recommendation to adequately recompensate, and the third one is to see the patient again. This is most important. Now again, what is now clinically important for the physician who has now to implement that? So implementation is now indeed the most important thing to do. And then we have these concerns. My patient has low blood pressure. My patient is stable, so why should I do something? Because he's doing well, he's still alive and there's no shortness of breath. My patient has impaired kidney function and my patient has diabetes. Just briefly. Low blood pressure separates patients with a particular high risk because these patients have more advanced heart failure, and also they are undertreated because they do not tolerate the drug, or, and this I think is most important, at least here in Europe, physicians are afraid that they produce adverse events, even if it is only dizziness. Yeah. So therefore, the chance is lost to treat these patients. Therefore, the outcome rate is higher. Here you can see the L-shaped, U-shaped curves, which is the association of hazard to indeed drugs. We looked at that in paradigm. I've shown it several times in India, but I think it deserves to be shown. We looked at patients with a blood pressure below 110, 120, 130, 140, 100, greater 140. And what you can see, people benefit the same in the very low hypotensive group. You can see also when you are called by a family physician, the patient has a blood pressure below 100. Then the first question should be, is he dizzy? Is he fainting? Did he become unconscious? Because the asymptomatic adverse events does not count. So these patients are at 4 months below 100 and these above 100. And there are two messages here. The first one is the relative treatment effect is the same. There is no heterogeneity between treatment effect, 20%. But the absolute risk is almost twice as high in those with a low blood pressure. And that means that patients with a low blood pressure, where physicians usually are reluctant to use the drug, they have a greater benefit, which is reflected by the area in between the curves compared to those with a high blood pressure. Yeah, and here you can see the association of risk reduction and also of the absolute event rate in the hospital arm. And you can see there is a fair line. The greater the risk is, the greater is the absolute risk reduction. Yeah, this is risk reduction, this is risk in the control arm. And this shows that there, where we are not so good in the high risk patients, where we do under treatment, they particularly benefit from these treatments. And this apparently to be a very important point. So you should fight to get the drugs in. My patient is stable, yeah? So why should I say something? He has an ejection fraction of 30, but he's not complaining. It's a difficult matter, complaining or not. So this is from the textbook. People who have advanced heart failure, highly symptomatic, class 3 and 4, they die from pump failure. They are symptomatic. Those patients who have asymptomatic or low grades of symptoms, they have cardiac arrhythmia and die from sudden death. You can see in those patients with a very stable heart failure of class 2, 50% die by sudden cardiac death. So therefore, there are no harbingers to judge of whether they're dying or not. The asymptomatic patient should also be treated, and this is shown here. You can see the sudden death, which is here the third pair of columns, is approximately 50% as in the textbook in cardiovascular death, and they might have no symptoms. Yeah? Worsening of heart failure in the stable heart failure population is less present. And indeed, as you can see, sudden death is reduced. Now, my patient has impaired kidney function. You can see that usually cardiologists get nervous when it comes to an eGFR of 45. But what we should keep in mind, and we put that together from the trials, is that indeed the margin of not treating a patient is 30 and below. And this is also the paradigm, the Pioneer HF study in the acutely heart failure patients. And you can see indeed that it works there. You can see it for the RAS inhibitors. It's 20% even for sham and also for ditch and the SGLT2 inhibitors. And Victoria with vericiguat goes down to 15 even. So that is a solution for patients who are really poor. And some of the beta blocker trials go down to end-stage renal disease, indicating that the green parts is really here more prominent as the red ones. So treatments should not be withheld in patients. So what about sacubitril/valsartan? CKD patients and no CKD patients. First of all, CKD are the broken lines. The risk is higher. Again, when it gets tricky, the risk is higher. And this is the treatment effect in the low-risk group with normal kidney function. This is the treatment effect in the high-risk group with impaired kidney function. Again, there where he gets tricky, patients benefit more. So don't be too reluctant to use the drug. The next point is the patient is returning and has acute kidney failure, problems with the kidney, rising creatinine. What happened? But this is in the what was looked in the Paradigm HF study is that there was at 6 months, 3 years, and 2 years, there was on sacubitril/valsartan less patients who needed a high diuretic dose. So on treatment, there is a reduction of the diuretics. So when these people are kept on a high diuretic dose, they might come back and are dehydrated and get a kidney problem. So if the patient is coming back to you, just think, leave them on the drug and just give them volume and water. And this is also the case not only here, but this is also the case in an outpatient study from other trials. And here you can see sacubitril/valsartan and the proportion of patients who have an increase in diuretic ejection. So these are the outcomes across the diuretic fraction. Now, the next question is, what about the effect on ejection fraction? So we have a lot of discussions of whether renal outcomes are really related to ejection fraction. This is a nice study where the renal composite is shown here, and here's the ejection fraction. And you can see kidney function not only improves in reduced ejection fraction, but here you can see the upper boundary of the treatment effect of sacubitril/valsartan crosses a line of neutrality around 60. So the kidney protection is better in these HFpEF patients when compared to other studies. And this is data from the Paragon study. Now, this is here what you see in the outpatient clinic and family physicians. You can see there is a diuretic unloading or reduction in all patients after sacubitril/valsartan. So the demand of diuretics is reduced, and it could be a reflection of an improvement of outcome. So diuretic need is indeed something which occurs sometimes. SGLT2 inhibitors, it is very clear among all of them that the ARNI is reducing the diuretic effect due to the effect of the preservations of natriuretic peptide, of course. There are some effects of MRA, but they are directly acting potentially as a diuretic. And the reason is clear. ANP, BNP increase eGFR because they increase blood flow to the kidney, and also they eliminate sodium, which is one of the target of diuretic treatment. My patient has diabetes. You can see that diabetes selects patients indeed who have a high role of a high prevalence of diabetes, and you can see that it predicts outcomes. Diabetes is bad, and unrecognized diabetes, undiagnosed, is even as bad as these patients. And then when it is recognized and treated, it's better than the other groups. So here you can see ejection fraction and diabetes act in common. So the lower the ejection fraction, the higher the risk is, but it is accentuated by the presence of diabetes. So the treatment effect is not significant different across all the different endpoints. It is shown here, and it is not different across normoglycemia, pre-diabetes, undiagnosed, and diabetes. So the diabetes patient has a higher absolute risk, and the same is here. He should be treated because he might get the greatest benefit. And one finding is very interesting. So we know that diabetes is a strong risk factor for heart failure, and here you can see that the prevalence of diabetes is reduced. So HbA1c is lower on sacubitril/valsartan than on enalapril, and one of the reasons, of course, is that there is a breakdown of several insulin promoting enzymes, and so there are peptides, and therefore this is the mechanism. However, what's most important is that the utilization of insulin goes down, indicating that this as a potential harmful mechanism leading to volume and sodium overload is reduced. So people on insulin have a 20 to 30% higher rate of hospitalization, and therefore providing the benefit of reducing insulin is another benefit. What do current recommendations state? The first is it should be given to all patients, and the drugs can support each other. And here you can see sacubitril/valsartan supports the potassium level. So here's sacubitril/valsartan, potassium is not rising as fast. And you can see here also that it prevents incident hyperkalemia, low or more severe hyperkalemia, in particular when there is a mineralocorticoid antagonist, indicating that it can also provide protection from side effects to another drug. So that is very important. So now how to sequence these therapies? ARNI should be initiated at a low dose. Beta blockers, SGLT10 just have one dose. And then all should be in there because the dose dependency is not clear, but it is clear that different mechanisms might protect better than others. So this is a very good read for how to introduce therapy. You can see that then you continue to up-titrate, titrate, because people on a high dose are doing better than people on a low dose. How could that be done? Drug layering in heart failure. There are two papers now coming out. First is look at patients who are early out of the hospital. They have high outcome rates and low treatment intensity. And you can see that the profiling of the patient should be important. High heart rate, the criteria are heart rate, blood pressure, atrial fibrillation, yes or no, or kidney dysfunction, yes or no. And then you can make a patient profile. So if the blood pressure is low, the heart rate is high, you start with the valproate and beta blocker, and then you can sequence around all these others. So with high blood pressure, of course, the ARNI is the first step together with the others. I have to say that this indeed is now applying for patients with a ejection fraction, not anymore just to 40, but even higher to 50, as a meta-analysis of Paragon and Paradigm have shown that these treatment effects for sacubitril/valsartan, but also for the other drugs, apply also for patients with what we call now mildly reduced ejection fraction. So there is another strategic change, and that is an extension of the patient population to be treated. So my take-home messages are neuroendocrine inhibition is a cornerstone, but that involves also neuroendocrine modulation with ARNI. And this add-on effect of modulation, meaning an increase of natriuretic peptide, has been shown to be superior to just inhibiting angiotensin II. The vulnerable patient need to be treated in the hospital. The first study looking at that was a Paradigm study. New evidence for post-acute and vulnerable patient has been generated. And this is now indeed also the cause for patients with higher ejection fractions, up to 50. The early maximal treatment is evidenced now. HFpEF remains a challenge. However, it can be treated by SGLT2 inhibitors and also by sacubitril/valsartan, in particular when the risk is high, and new guidelines will change the clinical practice, but we will have an update concerning the higher ejection fractions and also concerning HFpEF in a couple of months when other trials are out. Thank you very much for your attention.
Thank you so much, Dr. Michael Baum, for the presentation. It was an absolute pleasure. Dr. Chandra is here. So, Dr. Chandra, would you like to add any comments before the next talk, sir?
Yeah. Hear me?
Yes.
Yes,
Okay. So we must thank Dr. Michael for really, putting up the complete data set for, treatment of heart failure. And I think all of us agree that this is a new paradigm in the treatment of heart failure today. Use of ARNI has really changed things dramatically. And I'm sure 90% patients, or maybe more than that, are receiving ARNI today if they are able to tolerate it. So I think there is no other situation where we don't give ARNI unless patients with extremely poor renal functions like less than 15%, or sometimes I have seen that some patients actually start increasing creatinine very rapidly, and then we have to really, but those are very, very few number. So thank you very much. And yeah, Vidya?
Yes, sir. Yes, sir. So I'll just show the slides for the next talk, sir. You can, if you can introduce.
Yeah. So
Dr. Chandra, I think there's.
Today I'm going to now another, talk about another very revolutionary treatment. Yeah. Are my slides visible, Vidya?
Yes, sir. Yes, sir. Please go ahead, sir.
Okay. So, the treatment of severe aortic stenosis is also another paradigm change, which has happened in the treatment of cardiovascular diseases. And in adults with severe symptomatic calcific aortic stenosis, AVR was the only effective treatment before this. And we know that there was a low incidence of aortic valve surgery, especially in elderly patients and in patients where the risks were running high. So whenever these patients develop symptoms of angina, syncope, or heart failure, we all know that the survival becomes very, very less. 50% survival at 2 years, and only 20% survive at the end of 5 years. And all at the same time, paradoxically, these patients were not being able to be treated. So I think this was a disease which was left untreated in a large number of patients, with a life threatening those patients. So we know that those patients who are severe symptomatic aortic stenosis. So today we are treating only stage D, which is severe symptomatic aortic stenosis, where the jet velocity is more than 4 meters per second. The gradients are more than 40 mean gradients, and the aortic valve area is less than 1. That is the substrate which I am referring to today. There is still no indication of treating asymptomatic severe aortic stenosis by aortic valve replacement. And then the category of those patients who are symptomatic, who are the ones who are now candidates for this new therapy, those who have prohibitive risk of surgery, those who have high risk of surgery, those who have intermediate risk of surgery, and now we also have those patients who are above the age of 70 years or more than 65 years, have other comorbidities, and are in low operative risk also can be treated. So basically, we have to find out if the patient is symptomatic or not. And these patients generally have very, sometimes very minimal symptoms. And in fact, sometimes it is misunderstood by patients as normal signs of aging. And many patients will appear asymptomatic, but actually, if you ask them, and how many of them are there, almost 4 out of 10 patients will exhibit symptoms only when you start asking them questions, because they think that it is probably the signs of aging or symptoms of aging. So these symptoms are to be first investigated, and once we have these kind of patients, who come with these symptoms, what are the tests we do? There are two basic tests. One is, of course, echocardiography, which I showed you. And as soon as we start looking at echo and start, doing the gradients and all those things, then we come to know that whether this patient is having severe AS or not. And then cardiac cath has to be done to know the coronary status, and right heart cardiac cath, and sometimes in these patients has to be done. So once that is done, we risk stratify these patients, and if the the STS score is more than 4, then definitely they are clear candidates for a aortic valve replacement using a surgical valve replacement or a TAVR. And those patients who have intermediate or high risk or very high risk, they are clear patients for undergoing a transcatheter aortic valve replacement. So the real world, we know that it is full of these intermediate and high risk patients who are having severe symptomatic aortic stenosis, being above the age of 65 or 70 years. And in our practice also in India, we have seen such patients in large numbers now. And we are wondering what was happening to these patients earlier when there was no such therapy. So in this new paradigm, we are the surgeon, the cardiologist, the interventionist, everybody has come together to treat that patient who was left untreated. So you see, in the old paradigm, there were so many gaps. Now all the gaps have been filled so that he gets the complete care of this valvular heart disease by the help of new technology, which is transcatheter valve replacement. So this is the initial, the recommendations, where in prohibitive surgical risk, high surgical risk, and intermediate surgical risk, it was recommended. But now in low risk patients also, a TAVR can be done, especially if the patient is above the age of 65 or 70 years. So the decision has to be made by a heart valve team. Consideration of patient-specific factors have to be there, and of course, patient values and preferences are also to be considered when we are treating such patients who are undergoing a aortic valve replacement. And then, if the survival of the patient is more than 12 months for all reasons, then the recommendation is TAVR rather than medical therapy in these patients. So once the patient is diagnosed, then following this situation, the TAVR team will perform more evaluation, and the evaluation is basically to a cardiac surgeon should also be consulted in that, and evaluate the aortic valve complex by using echo, know exactly how is the rest of the anatomy, evaluate the CT scan to know the peripheral vasculature, the anatomy of the aortic valve, and all those things. These are the steps we do to know whether this patient is adequate for a TAVR procedure or not, and if at all, if it is, then what kind of valve we are going to use. So the test, the last test which we do in these patients is a CT scan, a CT angiogram, which is very, very important before we pick up these patients. So a large number of these patients have been now treated, and this is the global timeline. We started this procedure, in 2016 as an approval of the valve happened in 2016 in India. But before that, we actually started using it on a per patient basis in 2012. And then these about 90 to 100 patients got benefited when DCGI had to give approval for these patients. And then subsequently in 16, approval was done in India, and now the device is available on the shelf. So even if we have to do it tomorrow, we can do it tomorrow in a given patients once the evaluation is complete. These are the type of valves which are available. So this is the Medtronic valve, the Edwards valve, the Merrill valve, this is the My valve, and the Hydra valve. These are the 4-5 kind of valve. Now the Abbott Portico valve has also come, and we are also come to know that other valves like the Boston and other many other companies are coming up with newer valves to be used in these. So these are the kind of various progressive valves which are coming in, and I'm sure in the next 2-3 years we'll have a large number of these valves available. And here you can see that this is what TAVI has done to the treatment of heart diseases. It has taken the AVR world by storm. And you can see this technology has numerically surpassed the 50 years of surgical progress within 6 years. You can see in the slide that TAVI has really just surpassed the number of surgical valve replacements in many countries, including Germany here. And the 2-year all-cause mortality has been found to be better. And here you can see that compared to a surgical valve replacement, it is found to be a little better. And of course, outcome in intermediate risk patients was also found to be, almost as good or superior to surgery for a composite endpoint, and for individual outcomes of death and stroke. Also, it was found to be quite encouraging. So in low risk patients also, it has been now studied, and as you can see here, surgery versus TAVR in low risk patients, and these are symptomatic. Of course, it's not that they are not symptomatic patients. Again, you see that the chance of having a death or disabling stroke is lesser with TAVR than surgery. And here you can see that we have also kind of been riding on this bandwagon for a little while now, and we have done almost 350 cases in our center, apart from many other cases which we also proctor outside. So we have gone to about 450 cases now as a these experience. And of course, most of these patients are above the age of 65 or 70 years. Some patients we have done even up to 50 years, 47 years for various indications. The incidence of PPI has not been high with us, and of course, the success was very high. Only 2 patients have to be sent for surgery on the same day because of the patients had a pop out of the valve, which we pop outs are managed interventionally also. So we have done a large number of valve-in-valve cases, probably one of the largest here in India, and also alternate access. We have done from almost all accesses, which is like a carotid access, flavin access, and this is a spectrum of patients which we have treated. Old patients up to 92 years, severe COPD, chronic renal failure, severe LV dysfunction, thin chest wall, post-bypass patients, bicuspid aortic valve, porcelain aorta, very heavy patients like 160 kilograms patient with TAVR, and other indications like valve-in-valve, contraindications to long-term anticoagulation, young female with incomplete family, and post-traumatic with high risk. So these are the some of these indications. So to conclude, severe aortic stenosis is a broad spectrum disease. It has become a viable treatment option for many, from very high to low risk patients, and both type of valves, balloon expandable and self-expanding, has been found to be equally effective. So what is the limiting factor? The only limiting factor for TAVI in India today is the cost. So with this, I think I will stop here, and maybe I'll stop sharing now. How do I do that? Okay, so I will just stop sharing, and we can go on for the next session. Thank you very much. I think if there are any quick questions, it will be nice. Dr. Puneet and my other colleagues are here already. Thank you.
Thank you, Dr. Chandra, for the wonderful presentation. Dr. Puneet, would you like to add a few comments before we go to the next presentation?
Yeah, excellent talk from Dr. Chandra, and good demonstration of this very now emergent, I would say, technology of treating very high-risk patients of aortic stenosis. Of course, Dr. Chandra has an experience and expertise which no one in the country or very few can match. So that is something very rightly in his domain, and this is a wonderful treatment demonstration of how high-risk patients of aortic stenosis can be treated. My only one question, which I think I would just ask Dr. Chandra, is that how do we look at probably a asymptomatic high-risk aortic stenosis or a severe aortic stenosis, I would say, how justified are we in not treating asymptomatic severe aortic stenosis versus treating a low-risk patient of aortic stenosis with TAVR? I mean, a low risk but symptomatic. So is there any data here which justifies that asymptomatic cannot be treated or should not be treated?
Yeah, Puneet, I think I must say that, thank you for your comments and this question, which is very, very important. That, and now we have this data from the surgical who are having symptomatic aortic stenosis are the ones who need valve replacement, whether surgical or TAVR. Okay. In these patients, if these patients are low-risk patients, certainly, again, you have to take a decision whether the patient goes for a SAVR or a TAVR. And then based on the age of the patient, based on the other features of comorbidity, frailty, etc., one can decide whether this patient goes for a TAVR or a SAVR procedure. So I think that is where we are right now. So I don't think we have any clear recommendations. My other colleagues, Dr. Jaber, Dr. and Dr. Baum is also here from Germany, can also tell us what is the practice there in Germany.
Yes,
Dr. Jaber, what is your thoughts about this on asymptomatic severe aortic stenosis? That's a wonderful question, Puneet. Yeah, Dr. Baum.
Yeah, there is one trial now with a very small trial from Asia. I think it was Japan, where they provided that asymptomatic aortic stenosis from a surgical intervention benefits. But the point is, these are not many patients. And the other one, there was a mortality of 0 in the surgical group. So that was a little bit criticized that this is not responsible. So we do not treat asymptomatic patients. We have a strong position of the heart team. And that means that we decide everyone, but we make a pre-selection. So below 70, it's surgery. 70 to 75 is usually to be discussed, and above 75 is definitely TAVR. So that is the position paper together with the German Society of Thoracic Surgeons. That's our practice.
Dr. Chandra, it is awful results. You have 350. It's a huge number for the Indian condition, and especially the use of pacemaker is only very, very low number. It is 6. The aortic regurgitation is low. So I think having a fantastic results. And as far as we are concerned, we are a little conservative. We don't go for asymptomatic aortic stenosis, and we don't have that much huge numbers as yours. We are still started learning to walk.
Yeah. Yeah. So Jaber, absolutely wonderful comments. So basically, let me tell you, our pacemaker numbers are low basically because, we started our, TAVR program a little bit later. And then we learned that high implants are better for bicuspid valves at that time. And most of our patients are, in fact, 30%, 40% are bicuspid valves. So we started doing high implants. And that is probably one of the major reasons why the incidence of pacemaker has been, quite low in our patients in India. And it's not only me, and many of my colleagues have seen that the incidence of pacemaker implantation has not been high at all. Yeah.
Thank you, Dr. Chandra, for the presentation and the discussion. So, Dr. Chandra, would you like to introduce our next speaker for the day?
Yes. Yeah, I will introduce that. And maybe briefly, I'll have to leave in between. So my friend, Dr. Puneet, is going to really drive the discussions. He has kindly consented to do that. Thank you, Puneet. So let me introduce Professor Robin Chakravarti. Again, he is one of the top most cardiologists of the country. It's such a great experience. He's a vice chairman of cardiology services in Kolkata. And he is presently in the Medica Super Speciality Hospital. But I know that, he was earlier in Apollo and many other big hospitals of Calcutta. So Professor Chakravarti has been having great experience in treating coronary artery disease, valvular heart disease, and many allied interventions. So his expertise is far wide and broad-based, and starting even from heart rhythm disorders and electrophysiology, going to structural heart and coronary intervention. So I must invite Dr. Chakravarti quickly now to start his presentation. Robin, Dr. Robin.
Yeah, thank you very much. So we think we'll start straight away. I'd like to share my screen. One minute, let me go there.
We don't see the screen.
Do you see it now?
No.
Is it visible now?
Yes,
Yes, sir.
it is.
Yes, yes.
So I think it's a great session this evening. I thought that we are focusing towards the elevated dysfunction subset of cardiovascular patients. And my assignment is management of coronary artery disease with low ejection fraction. So let us say if we get a patient like this, as you can see, this is the coronary anatomy, extensive coronary artery disease, both on the left side as well as on the right side. And maybe another one, something like that. Again, significant triple vessel disease with low ejection fraction of 36%. So what you're going to do? And this is a kind of experience which not myself alone, maybe most of us in this panel, as well as many of my colleagues right across the globe are facing such a scenario. So I would like to address such scenario in a short span of time, something like 15 minutes or so. We know from last something like 30 years or so that the left ventricular function is an important determinant of long-term prognosis of coronary artery disease. This is the data which we have been reading for years together from CAS registry. So, and it's a famous publication from Circulation in 1994. And from there onward, later on, Dr. Leon Opie has actually shown that revascularization even today continues to remain an important option of treatment, even in patients of left ventricular dysfunction with coronary artery disease. So if you have this diffuse disease, something like chronic total occlusion or even extensive disease of the coronary arteries, certainly the cardiologist or interventional cardiologist should make an attempt to proceed for complete revascularization. Maybe you can do PCI of some of them, maybe coronary artery bypass graft as a secondary intervention, or maybe in combination with both, because it has been proved that with this kind of treatment, there is a significant improvement of left ventricular dysfunction. No denial of this fact. This has been proved time and again in the literature, as well as in our clinical practice. Similarly, this is a famous data by Patrick Sears and his colleagues, published a very famous article in New England Journal of Medicine in March 2009, that what would be the choice of revascularization. There are controversies like whether to go for PCI, whether to go for bypass surgery. And then later on, somewhere around 2007, this information came out, syntax score. And depending upon the syntax score, then there's further division from syntax 1 to syntax 2. We know that, yes, you can actually consider the option of PCI or coronary artery bypass graft, depending upon the syntax score. Of course, you have to take into consideration of the other parameters, something like left ventricular function. It is equally important for us to recognize that left ventricular function is an important component even for the revascularization strategy. So revascularization continues to remain an important option of treatment of coronary artery disease with low ejection fraction. Nonetheless, we need to remember that concomitant medical treatment are of paramount importance, even in patients undergoing revascularization, like concomitant beta blocker, statin or other lipid-lowering agents, ACE inhibitor, because there is some discussion of possible anti-atherosclerotic effects of ACE inhibitor in coronary artery disease, which I'm not quite sure whether ARNI has such anti-atherosclerotic effect on the coronary artery disease. Antiplatelet, of course, is an important medication, and at the same time, the medications for diabetes, hypertension, and other drugs for other medical problems need to be continued. And today, in 2022, we must consider SGLT2 inhibitor, because we know that those patients, even in non-diabetic patients with a cardiovascular disease, SGLT2 inhibitor is an important component of treatment of cardiovascular disease. More so probably in preserved ejection fraction, but certainly with low ejection fraction. We should continue to have lifestyle modification. And in presence of low ejection fraction, ARNI remains an important treatment after revascularization. We're not quite sure that whether or not any role of Hersigua, the new drug which is coming up for heart failure management. In this connection, it is important, as I was talking about antiplatelet, there is a data coming up from this Korean group. They actually mentioned that the correlation between platelet and lymphocyte count called PLR, which actually considers an important parameter, a hematological parameter to assess the coronary artery disease severity in asymptomatic patients with low ejection fraction subgroup of patients. So in a patient who has got otherwise asymptomatic with low ejection fraction, but hematological parameters shows an altered platelet lymphocyte ratio, one has to consider coronary angiogram to exclude or that whether or not there is an associated coronary artery disease, because in that case, the treatment, the modality of intervention, as well as the long-term outcome remain different. So similarly, and this is the data from the Korean group in 6 years ago, has shown that in asymptomatic heart failure patients with low ejection fraction, and they have actually found that there is an abnormality of platelet lymphocyte ratio, PLR, and when they did an angiogram, they found that there is a possibility of having coexistence coronary artery disease. Severe atherosclerotic group is substantially higher level of this PLR as compared to the other group. So the pre-coronary angiogram PLR level, as well as variety of clinical variables, including the LDL cholesterol and other parameters, are the independent marker in this group of patients. So potential association of high platelet lymphocyte level with severe atherosclerotic disease process in asymptomatic heart failure patients remains a significant observation in heart failure patients. So a simple hematological measurements of platelet lymphocyte ratio helps to identify the presence as well as the severity of coronary artery disease and the atherosclerotic process prior to take those patients up for coronary angiogram. And it has been shown that graphically that a significant group of such patients remains under this curve. And this slide clearly shows that high platelet lymphocyte ratio has a close correlationship with severe atherosclerosis in presence of left ventricular dysfunction. It's very important, simple, as well as meaningful observation in patients of heart failure with low ejection fraction, that whether or not presence of coronary artery disease is important to determine the therapeutic plan, the outcome of this group of patients. Now, we have to again highlight that along with this, presence of other factors like age, diabetes mellitus, hypertension, abnormal cholesterol are equally valuable and important predictors of atherosclerosis, and at the same time indicate the severity of atherosclerotic process. So this has been well talked about by Michael Baum. Dr. Baum has clearly mentioned that the paradigm trial has established the role of ARNI in presence of heart failure. There is no second opinion about that. Now we are convinced that ARNI is an important component of treatment in patients of heart failure, particularly with low ejection fraction, because it has been shown to improve the outcome, decrease the hospitalization, decrease the rehospitalization in patients of heart failure with reduced ejection fraction, because it has been proven that if you compare ARNI with angiotensin receptor antagonists like enalapril, it has clearly shown a significant reduction of heart failure-related hospitalization, rehospitalization, and all-cause hospitalization-related mortality. No doubt about that, and we are convinced about this. But there should not be any therapeutic inertia. So we have to talk about, this is a very interesting observation, which I also personally felt, although has equally been talked about this year in European Society of Cardiology meeting, that there is a kind of an inertia of introduction of such treatment in heart failure patients, because a risk treatment paradox concept has been proposed, meaning the sicker patient, many people feel that if the patients are sick, you hold yourself to comments on ARNI treatment, which probably is not true, especially if you get an ischemic heart disease patient with low ejection fraction. You have already done revascularization, you've already commenced that the patient is already on beta blocker, but at the same time, patient is not significantly improving or not sort of clinically there is not much of improvement. Do consider introduction of ARNI therapy in this group of patients, rather than being hesitant. Be courageous enough and think that whether ARNI introduction will be extremely helpful. When you introduce the drug, you go in a very graded manner, in a slow dose manner, and progressively build up the dose depending upon the tolerance of the patient, depending upon the hemodynamic status of the patient, depending upon the biochemical parameters of the patient, like urea, creatinine, electrolytes, and other kind of thing. Because we cannot deny the potential benefit of treatment initiation and up titration, because that must not be underestimated, because it may actually reflect that this belief that the symptoms are related to medication is not true, because the symptom can be related to illness itself. And if you improve the symptom with the medication like beta blocker, like other drugs, like your antiplatelet drug, or even statin, along with ARNI, your actually patient may get more benefit. And it is important that we may not have an exclusive trial on coronary artery disease with ARNI at the moment. We have got a broad-based trial, but I'm sure in a subgroup analysis, if you really dissect those trials, you'll be able to be convinced that even coronary artery disease with low ejection fraction subgroup of patients will equally get benefit with ARNI therapy, along with concomitant other medications like beta blocker or even statin, as well as the other drugs, for example, antiplatelet drugs. So therapeutic inertia in the pharmacological management of heart failure with coronary artery disease and reduced ejection fraction must be understood and accordingly must be prescribed. So the guideline-directed medical management of heart failure with reduced ejection fraction, it has been, we know that there is a 4 pillar of treatment which we have been talking about for years together, and then we know that this is an extremely helpful treatment like beta blocker, the ARNI, then you got what is called the SGLT inhibitor, as well as the small dose of your MRA is extremely helpful in this group of patients. So MRA, beta blocker, ARNI, and SGLT inhibitor, important pillars of treatment of heart failure patients. The newer drugs like vericiguat can also be helpful, and the newer drugs are also coming up. I'm sure in next couple of years' time, in the heart failure treatment armamentarium, particularly the coronary artery disease with low ejection fraction, I'm sure that these patients will be profoundly benefited. So to get into it again, an aggregated effect of guideline-directed medical treatment has been explored in various meta-analyses. It has been shown that ARNI, beta blocker, mineralocorticoid antagonist, MRA, as well as SGLT2 inhibitor to previous ACE inhibitor and beta blocker certainly cause reduction in all-cause mortality. Perhaps it is equally true in patients of coronary artery disease with low ejection fraction after revascularization. And those patients who are completely unsuitable for revascularization, certainly those patients also should get, and they do deserve to get these 4 pillars of treatment with LV dysfunction. because it improves the quality of life, it decreases hospitalization, it decreases rehospitalization, and at the same time it improves the probably the outcome of this group of patients. So as I told you earlier, that MRA followed by SGLT2 inhibitors saw the greatest reduction in the composite endpoint with the decrease of nearly 40% of improvement. And this is extremely important for us to understand that in heart failure management, equally important in coronary artery disease with low ejection fraction, such quadruple therapy has a profound role. And after RNA therapy is initiated, beta blockers should be considered, as well as other drugs like MRA. In small group of patients, I have to say that if you find that revascularization is not optimal, suboptimal revascularization, sometimes I personally feel that nitrate addition may be helpful. Or if you find that this group of patients are intolerant to a progressively higher dosage of RNA therapy, maybe concomitant addition of nitrate in combination with hydralazine is helpful in this group of patients. There is no randomized trial to confirm this kind of therapeutic protocol, but this is a kind of observational statement which I would like to mention in this meeting. So when treated with this 4 pillar of combination, the life gain at least nearly 8 years. Even it is equally important at the elderly subgroup of patients beyond 70 years of age. Early initiation of multi-drug therapy is the key, particularly with patients who are younger, and more effect are being seen if you start early in the disease process. So multi-drug therapy appears to be a necessary form of treatment in polypharmacy for the treatment of heart failure with reduced ejection fraction. It is equally true for coronary artery disease with low ejection fraction. So to summarize, when you treat these patients of heart failure with coronary artery disease and reduced ejection fraction, think of ACE inhibitor. I have to say again that ACE inhibitor may have some anti-atherosclerotic effect, but when you replace it with ARB, then probably ACE inhibitor may not be justified to continue as an additional drug. Beta blocker, yes, has to be given. Neprilysin is an important component because I have to say that atherosclerotic process has got an inflammatory process, and neprilysin inhibitor has an ability to mock those inflammatory material from the atherosclerotic inflammatory process, may be helpful even in atherosclerotic coronary artery disease. As I said earlier, hydralazine and nitrate combination is equally helpful for those patients who are intolerant or with a elevated level of creatinine or already very compromised chronic kidney disease. In small group of patients, we have to combine with ivabradine, and those patients with clinical evidence of fluid retention or pulmonary congestion certainly deserve to get diuretic. Maybe a small dose of loop diuretic would be helpful to start with. Once the patient improves, then gradually you can taper this diuretic and see how the patient responds. So this is a slide which has, again, from the Korean group, has shown that if you actually combine such therapy, you can actually show the biochemical improvement of parameters like antiprobiot reduction, reverse remodeling, and reduction of the hospitalization and all-cause mortality. So to conclude, in coronary artery disease with low ejection fraction, revascularization continues to remain an important option. Concomitant medical treatment must be continued along with probably SGLT2 inhibitor. Today, ARNI holds an important component of medical therapy in coronary artery disease with reduced ejection fraction, along with other medications like beta blocker, sometimes nitrate, statin, and antiplatelet drug. But when you commence ARNI, start in an up-titrating dose schedule with monitoring of renal parameters, renal biochemistry, electrolytes, and monitor the blood pressure and hemodynamics, if possible, clinically. Serial monitoring of left ventricular function is important. And if you see the left ventricular function is improving with your RNA therapy, never discontinue RNA therapy. Continue RNA therapy, even if you achieve an ejection fraction from, let us say, 35% to 45% and beyond. And if a patient of coronary artery disease with low ejection fraction gets hospitalized with acute decompensated heart failure, after initial stabilization, RNA may be an important drug to commence as an inpatient and see the progress of the patient and continue that while the patient is being discharged. You need to monitor the biochemistry as well as the blood pressure and other parameters. We also need to have perhaps a very specific trials of RNA therapy of coronary artery disease with low ejection fraction to substantiate a clear guideline of commencement of RNA therapy as the primary treatment of coronary artery disease with low ejection fraction right in the beginning. That is important. Again, I have to say that RNA has got an anti-hypertensive effect. So some of these coronary artery disease patients may have associated hypertension. So RNA does help in controlling the blood pressure. So therefore, by doing so, it may actually improve the outcome and make the clinical condition far superior. So the patient remains much better with the medical treatment along with other modalities of therapy. Thank you very much for your attention.
Thank you so much, Dr. Chakravarti, for this very important presentation. Dr. Verma, with your permission, if we can go to the next presentation and take the questions once all the presentations are over. Is that okay, Dr. Verma?
Yeah, perfect. I think we're already running late, and there's an important talk from Dr. Jabir. I think we must. But excellent deliberation by Dr. Robin, as usual. He's always been a very good orator and always impressive to listen to his views, which by and large are, I guess, always directed by whatever we have the data from randomized controlled trials, and how well he practices his medicine is how well he professes as well. And this is what the talk was all about. So excellent talk, Robin. We'll take it up later if time permits on certain questions which I would have for you. Thanks.
Okay, go ahead.
Dr. Verma, would you like to please introduce Dr. Jabir as well?
Yeah, good evening, and final talk for the day is from Dr. Jabir Abdullah Kuti, who is a senior interventional cardiologist at Lizzie Hospital, Ernakulam. He's got a huge CV before us, and I guess it suffices to say that in the interest of time, we should listen more to his, we understand he's got excellent credentials, but I think we would be very keen to listen to his deliberations. Dr. Jabir, please.
Thank you, Puneet. So I'll be discussing the next part of the treatment management of the patient, coronary artery disease and low ejection fraction or LV systolic dysfunction. I hope I'm audible, isn't it? Okay.
Yeah, please.
So this is the extension of what Dr. Rabin Chakravarti has already discussed. That is the management of patients with coronary artery disease, LV systolic dysfunction. So I'll deal with a particular part of the management, that is revascularization in patients with low ejection fraction, which we come across in a large number of patients day in and day out. Does it really improve the ejection fraction? Does it improve the mortality and morbidity? And what is the type of revascularization we should go for? Is it a percutaneous coronary intervention? Is it a coronary artery bypass grafting? And what's the influence of viability on the outcome of revascularization? And what are the evidences in support of all these things? So I'll be discussing these points in the next 15 minutes. So revascularization in ischemic LV systolic dysfunction, we expect an improvement in the global and regional mechanical as well as the metabolic function of the left ventricle. And of course, we hope for a reverse remodeling, a decrease in the LV and diastolic volume, decrease in the LV and systolic volume, and an increase in ejection fraction. And this improvement in the LV function, it should translate into benefit, clinical benefit in terms of morbidity and mortality. So LV recovery with revascularization. Whatever observational data is available with us, they have shown that in 50% of the patients with the stable ischemic heart disease and LV dysfunction, revascularization has led to an improvement in LV ejection fraction. The data of the randomized, we don't have much randomized. There is a real paucity of randomized control data in this particular subset of patients, LV systolic dysfunction and coronary artery disease. The PROTECT-2 and the CWAT, they revealed that 57% of those patients who had undergone a PCI supported hemodynamically by mechanical cardiac support had an increase of at least 5%. It was a median was a 6.5% improvement in the LV ejection fraction following the PCI. And they found one more thing. The ejection fraction improvement is much greater when there was an extensive revascularization or more vessels treated. And the sub-study of the PROTECT, they revealed that reverse remodeling with LV ejection fraction produces a LV ejection fraction increase by 13% in half of the patients, such a significant benefit. And this was also seen more in those with extensive revascularization. And those who had remodeling, reverse remodeling, not remodel as it is reverse remodeling, they had less major adverse cardiac events. So this is the last meta-analysis which was published recently. Left ventricular functional recovery after coronary revascularization and medical therapy. A meta-analysis and a systematic review. What they found, statistically significant improvement in LV ejection fraction following coronary artery bypass grafting. PCI also resulted in a statistically significant improvement, and no improvement in ejection fraction with medical therapy alone, and numerically higher LV ejection fraction in those patients who underwent CABG, and better ejection fraction recovery in those patients who had a low ejection fraction to start with. And what type of revascularization? The randomized control data regarding the revascularization, we don't have much data. The best data available is the stitches extension data of 10 years. But you should know that this is surgical revascularization versus medical therapy, not surgical revascularization versus PTCA. And this is pretty old, 2002 to 2007, but even then around 92% had lima graft at that time. So death from any cause, death from cardiovascular cause, and death from cardiovascular death from any cause of or cardiovascular hospitalization, in all these outcomes, there was an improvement provided by coronary artery bypass grafting. And this actually came later. Initial 5 years, there was no much difference. Actually, in fact, the initial 2 years, there was an increase in the event rate. But later on, as the time goes on, the CABG arm improved and they produced significant benefit. And this benefit was an incremental median survival of close to 18 months and one cardiovascular death prevented for every 11 patients treated for 10 years. But there are certain limitations of this study. There was crossover to the CABG in 11% of the patients put on medical therapy or in the medical therapy arm in the first year. And crossover to CABG over 10 years is close to 20%. PCI in 44 patients of the CABG arm and 55% of medical therapy. And you can see better results in NYHA class 3 or 4, more severe LV systolic dysfunction. It's more vessels treated. The most important thing is triple vessel with LV dysfunction, they derived a greater benefit. And when they looked at the sub-study where viability was assessed, they could not find any significant impact of the viability assessment or presence of or absence of viable myocardium could not influence the result much in terms of outcome. But at the same time, presence of viable myocardium was associated with a better improvement in the ejection fraction, but somehow this was not translated into an outcome benefit. So these findings of this study, they do not support the concept that myocardial viability is associated with the long-term benefit of coronary artery bypass grafting with ischemic cardiomyopathy. And the presence of viable myocardium was associated with improvement in LV systolic function, irrespective of the treatment, but such improvement was not related to the long-term survival. But here, viability assessment was not a randomized one. And they looked at only one thing, whether viable myocardium is present or not. For the final analysis, they did not look at how much viability, what percentage of the myocardium. So these things were not assessed, and only 2 types of viability assessments, dobutamine stress echo and SPECT was assessed, not MRI or PET. So this is not a what called a foolproof study as per the current standard. And we don't have any RCT on impact of viability assessment in percutaneous coronary outcomes in LV dysfunction. And the myocardial viability for decision-making concerning revascularization in patients with LV dysfunction and coronary artery disease in 2015 meta-analysis, their conclusion is available data are inconclusive regarding the usefulness of myocardial viability test for decision-making process concerning revascularization in LV dysfunction coronary artery disease. So viability prior to revascularization is not for all, but there are situations which require greater precisions in defining larger infarcts, especially when the surgical morbidity is excessive and also when there is inability to achieve complete revascularization. So a subset of patients may require viability assessment, it's not for all. And PCI versus coronary artery bypass grafting in patients with LV dysfunction, do we have the evidence? The Excel trial data, 3-year follow-up, the composite rate of death, MI or stroke was significantly higher in patients with heart failure and reduced ejection fraction compared with the normal or mid-range ejection fraction, which was driven by an increased rate of all-cause death, but no significant difference in the clinical outcomes after PCI versus CABG, especially in terms of the hard endpoint of mortality. So prolonged follow-up could provide important insights on differences in clinical outcomes that might emerge over time. This is the New York heart failure, the New York registry data, which is the one most important observational data that is available regarding stent versus coronary artery bypass grafting. It was the everolimus eluting stent in multivessel disease, severe LV systolic dysfunction, revascularization. What they found was that no significant difference in the death. There was a difference in the revascularization, more revascularization in the PCI arm, and more myocardial infarction in the PCI arm, and more stroke in the CABG arm. So among patients with multivessel disease and severe LV systolic dysfunction, PCI with everolimus eluting stent had comparable long-term survival in comparison with CABG. And the last data, which was available in 2020, long-term outcomes in patients with severely reduced left ventricular ejection fraction undergoing PCI. This is also retrospective data from Ontario, coronary artery bypass grafting. So this is contrary to the previous data. CABG had a real advantage over PCI regarding the long-term survival, not only long-term survival, other causes like myocardial infarction, heart failure hospitalization, and also the composite endpoint. The benefit was there at even 30 days, but the problem is problems of retrospective observational data. But most important thing is all these data available with us, CABG versus PCI, was all comparison of the previous PCI with the CABG, and the contemporary PCI is a totally different substance. The contemporary PCI with the neo stent, the thin strut stents, a lot of improvisation has come into the contemporary PCI, and we don't have a real comparison of contemporary PCI with the other revascularization techniques. So the modern day PCI, we use intracoronary physiology to assess the appropriateness, plaque modification in severely calcified lesions, imaging to guide and optimize intervention, thinner drug-eluting stents with the less strength thrombosis, increased success of the PCI CTO, so better CTO PCI, availability of mechanical circulatory support devices, new one which really helps, and improved approaches to bifurcation lesions, finally resulting in an increased likelihood of achieving complete revascularization with a PCI, and that is the crux of the benefit. So, arguments towards PCI. Contemporary precision PCI is totally different with the use of no stents, hardware, adjuvant medical management. That also is extremely important. The powerful dual antiplatelet therapy, the high intensity statin therapy. So, and the heart failure treatment, the 4 pillars of treatment, which was beautifully narrated by Dr. Rabin. Improvement in CTO PCI, which offers complete revascularization in more, and coronary imaging and physiology with guides to provide a precision PCI. And outcome of modern PCI versus contemporary CABG in LV dysfunction is not known. So contemporary PCI is altogether a new variant whose impact on LV dysfunction is untested. And what the guideline says, 2017 appropriate use criteria for coronary revascularization. 35 to 50% ejection fraction, CABG, class of recommendation 2A, less than 35%, 2B, and for PCI, insufficient data. But appropriateness, they looked at the appropriateness, and 3 vessel disease with less complexity and symptomatic despite drug therapy, in many of the situations, it was considered to be appropriate, but 3 vessel disease of high complexity with a syntax score of more than 22, regardless of the diabetes, it was not really appropriate. They did not consider it as appropriate. ESC 2018, CABG is recommended as the first revascularization strategy choice in patients with multi-vessel disease, and acceptable surgical risk is class 1. In patients with 1 vessel disease or 2 vessel disease, PCI is an alternative to CABG if you can achieve a complete revascularization, class 2A. And 3 vessel disease, it is a shared decision making with the patient, heart team, and looking at the unexpected completeness of revascularization, diabetic status, and comorbidities. And 2021 ACC/AHA CAI guideline for coronary artery revascularization, they have put LV dysfunction in a special clinical situation under the heading unanswered questions and future directions. That is where PCI versus CABG in 2021 guideline. So how can we predict the LV recovery after revascularization? This is one scoring system, not validated, but seems to be quite appears quite useful. You look at LV wall thickness less than 5, it is recovery less, no response to low dose dobutamine, late gadolinium enhancement of more than 50%, negative viability in SPECT, negative for hibernating myocardium in PET. These are the major risk factors, major predictors, and the minor one, a low ejection fraction less than 20%, increased LV and diastolic dimension, increase in diastolic volume more than 170, and systolic volume more than 90 ml by echocardiogram. If you have 4 major criteria, extremely poor chance of return of LV function to normal, and 3 major plus 1 minor, or 2 major and 2 minors, the chance of recovery, LV function recovery, is less. So what is there for future? We don't have a planned RCT to compare PCI with CABG in LV systolic dysfunction. We need such RCT data on CABG versus PCI in LV systolic dysfunction. And we have to study the impact on a heart failure hospitalization and quality of life metrics of revascularization. And then what's the benefit of complete revascularization with a contemporary PCI? So there are a lot of unanswered questions and puzzles we have to solve, and we have to go for more data, registry data, the real world data, as well as the randomized control data. But the future looks promising. We have 3 trials which will be evaluating such patients. The CHIP BCSI is 3, the PROTECT 4, and the revived BCI is 2, where PCI versus medical therapy, but we don't have a randomized control trial on PCI versus CABG, which is the essential one. So my final thoughts on this subject: revascularization in ischemic LV dysfunction really improves the outcome. PCI and CABG both are viable revascularization options. Complete revascularization is the key to the success. A residual syntax score of less than 9 should be our aim. And we should aim for precision PCI whenever PCI is done in patients. It's for all PCI, especially in PCI with patients who have LV systolic dysfunction. And coronary artery bypass grafting may be the preferred revascularization strategy in complex anatomy and diabetics with triple vessel disease. And viability tests may be of value in selected population. Thank you so much. And I take this opportunity to invite all you to, or welcome you to Kochi in August 12, 13, and 14 for the a truly physical meeting, Imaging and Physiology Summit by the Imaging and Physiology Council of India, national meeting. Thank you so much.
Thank you, Dr. Jabir. I would now like to invite the panel. Before that, Dr. Puneet Verma, thank you so much for graciously taking over and moderating. But to give a brief introduction about Dr. Verma and Dr. Sudhi, who have also joined us today. Dr. Verma is a director and chief cardiologist at ACE Hospital and Vascular Institute in Mohali. And Dr. Sudhi is interventional cardiologist at Citizen Hospital, Hyderabad, Department of Cardiology. Both of them have very extensive experience and a very prolific CV. Because of lack of time, I will not be able to read through them, but I would like to invite Dr. Sudhir, Dr. Verma, and all the other doctors present today for a discussion. Dr. Puneet, over to you, sir.
Yeah, thank you very much. And I think it's apt that Dr. Sudhir comes in now. It's been a long waiting for him as well. And we are towards the fag end of the meeting. And certainly at this time, I would certainly invite comments from our other panelists, worthy speakers as well on the subject. And Dr. Sudhir, over to you, please.
Thank you, Dr. Verma. Thank you so much. Those were really fantastic talks on, Artery, Tower, and then revascularization, and also from Dr. Arvind Chakravarti. I just want to start off with a question to Dr. Baum. We talked about blood pressure. What is the lowest you're going to tolerate? I know we're going to go by symptoms, but what if somebody's systolic is like 80? The reason why I ask is, you do have this cohort of patients who's kind of really falling into that advanced heart failure therapy category, who's kind of ready for transplant. And whenever you talk with the transplant surgeons, they're like, they really are reticent for us to continue these drugs because they're profoundly vasoplegic when they tend to operate on these people. Any comments on that?
Yes, indeed. I would stick to the indications which are given by the guidelines when I do it on the outpatient, by the studies, when I inclusion criteria, when I do it on the outpatient clinic. However, it gets tricky. So when it's 100, it's okay. When it's below 100, this is something I do sometimes if there is no other chance to get any drugs in and to improve maybe the outcome of the patients. I give it sacubitril valsartan as a half dose. I would also give a little bit of volume to see whether there is over-treatment with diuretics. And the very first step would be to look whether there are any things who are reducing blood pressure to get the blood pressure up. And these could be nitrates, it could be an alpha blocker for prostate disease, and even sometimes a calcium blocker for some forgotten calcium blocker when the patient was still in hypertension. So this is the first thing one should do. I would then do it only in the hospital, and it is outside the indications or the proven data in the trials. But what can you do? What can you do else? Nothing. So therefore, we have seen in the blood pressure analysis that when the heart failure improves, and when you get over this period, then there might be a chance that the blood pressure is going to increase. Some other tricks are that spironolactone acts more strongly on blood pressure, so should be replaced by eplerenone. SGLT2 does not have a big effect on blood pressure. That is just published. That can be left in. And therefore, the patient profiling I've shown you means to reduce heart rate when the blood pressure is low first, and then you can use ivabradine, which statistically increases blood pressure by 2 millimeters of mercury. So there are many things. I think then it is an individual decision of how the patient looks like.
Fantastic comments. Thank you so much for that valid input. Any comments from Dr. Arvind Chakravarti, Dr. Chapir?
I think that my only comment in this situation is that two things. One is that when you really talk of blood pressure, it is very important to know what was the baseline blood pressure when you commence the medication, which is important. If you find that there's a significant drop from the blood pressure when the Artery was commenced, let us say it's commenced at 130 systolic and blood pressure dropped something like 90, then one has to be really, really cautious. That is one. Second point is, it is equally important, many of these so-called quote unquote heart failure patients, they restrict fluids significantly. So that has to be taken into account, that there are some other factors like, as Dr. Baum mentioned, that there is concomitant medication, the fluid restriction, some other drugs, and their dietary intake, so many factors involved. And then that can actually contribute towards the lower blood pressure. One has to be careful, and you need to counsel and talk to the patient clearly that, look, these are the things one has to be aware about. So it's important. Many of those patients may have nutritional problems. Their hemoglobin could be low. That has to be taken into consideration. Then other thing what I observed that many of maybe in Indian physicians that they start something like 25 milligram of Arni to start with. That is rubbish. 25 milligram twice daily has got no such dose schedule. If you are happy to start at 50, if you're not happy, don't commence. That would be my comments on this.
So I caught you caught my attention on the nutrition aspect. I was just going through some older talks from the Heart and Lung Transplant Society, and there was one talk on particularly on salt intake. We tend to restrict salt in these people, right? But apparently, in severe LV dysfunction, a little bit of salt is okay because it's going to retain the volume, and the pumping function is going to, it's going to increase the preload and hence the contractility. Any comments, ideas?
Yeah, I think there is a publication came just, I think, 2 weeks ago, which has shown that salt restriction has got no correlation with the improvement of mortality and outcome.
Great. And Dr. Jabbar, just on your talk, I mean, it always generates a lot of discussion, particularly the stitch sub-study on the MRI. We still do it because I feel at least we can inform patients, look, there's limited viability. We can still go ahead, but there's a chance your LV function may not improve. What does others do? What's your practice in this sort of situation? Or do you actively discourage them from having CPG?
Though we feel that with the currently available data, there is no necessity to send all patients for viability assessment. The surgeons do. If we send the patient for coronary artery bypass grafting, most of them prefers to get the viability done, and we have our on-site cardiac MRI also for viability assessment. But what they have found is viability patients with viability, their LV function recovery is good, but that does not produce a differential outcome benefit. That outcome is not correlated to that. We don't know what is the reason, but perhaps it may be because of the fact that we have to calculate what is the total scar formation or scar index. If the total scar is very high, then it may not be beneficial. But though the viability is not there, but the scar formation is not that great, then that patient, even those patients without viability also has improved, outcome was improved, and even there was improvement in the LV ejection fraction. So right now it's, we don't have definite recommendation, but what we generally practically follow is look at the echocardiogram. What is the LV size? What is the thickness? What is the assessment of the scar? And MRI, what is the late gadolinium enhancement and the scar, total scar volume? And so depending upon this, if the total scar volume is not that great, the thickness is relatively maintained somewhere around 7, 6, 7, and we may go ahead with the revascularization.
If I may ask the same question to Dr. Baum, you probably must be doing a lot of cardiac MRI in these sort of situations, right? What is your experience?
So usually the question is when you do vitality studies, then you of course you can see is it a scar or is it viable, but the border zones of viability you cannot detect. And I'm always surprised when I don't do it and I do a PTCA that the patient is improving symptom-wise. Because in shortness of breath in the heart failure arena, you talked about poor ejection fraction can also be an angina equivalent. So I don't feel safe with these technical issues. If it's an easy thing to do the intervention, we are looking, the intervention or even the operation when it's not so easy, we are looking to get the patient as best revascularized as we can. Yeah. Knowing and taking into consideration that the outcome is going to be improved, but also we are not sure whether we revascularization may be a vital myocardium. Yeah, so we are very liberal to do that.
Dr. Baum, there are some questions from our previous interactions with the doctors, which I think you can better clarify on ARNI therapy. First question is the asymptomatic patients. What's the benefit of ARNI in the NYHA class 1 and class 2 over the other AC inhibitors or ARBs? Second was because a lot of diabetic patients also have underlying chronic kidney disease. So your comments on these patient profile with diabetes and the chronic kidney disease, what would be the benefit of ARNI therapy? Third is the question on the ejection fraction versus increased ventricular volume, because a lot of cases we see that the ejection fraction is still normal and the patients have other echocardiographic markers of heart failure. So in this case, in increased ventricular volume as a marker over the ejection fraction, what should be considered? And another question is a hypertensive patient.
Maybe I can start with the first one, because it's an immense. Yeah. So the first one, let's take the one with the CKD. So of course, and I've shown you the data, if a patient is in CKD, then of course you can use it down to an eGFR of 30. And then there is a trend of improvement of CKD, and the patient in CKD benefit absolutely more and relatively the same as patients without CKD. Yeah, so therefore it should be done. The second question, or one of the many questions, was what about diabetes? I've shown you that the data in diabetes are stable, but what is the good thing, and even in patients with diabetes, that the utilization of insulin is reduced. And insulin produces adverse effects. So in particular, patients with diabetes should receive the drug. To improve diabetes and of course heart failure outcomes. And again, the diabetic patient has a higher absolute risk, and therefore by having a similar relative risk reduction, they benefit more than those without diabetes. And what was the third one?
One was on the asymptomatic NYHA class 1, class 2 patients. Yeah.
So first of all, the paradigm study was done in patients with stable heart failure, class 2 to 3, very few 4. Asymptomatic, meaning patients who are not complaining, is often an outreach for a poorly taken medical history. Yeah. So first of all, what does it mean? Is the patient inactive, or does he have symptoms or no symptoms because he is inactive? That is a very tricky point. We have no data in asymptomatic left ventricular dysfunction as we have with patients with ACE inhibitor. So that was a soft prevention trial. But still, I doubt that the patients are really asymptomatic when they have a poor left ventricular ejection fraction around 35. In this case, where I'm not sure, I look at the NT-proBNP. When that is really increased, then you have an increase in wall stress, and then it might be good to treat these patients because the reduction is strong, and the reduction of NT-proBNP is strongly related to an improvement of outcome. So symptoms is not an indication, but left ventricular dysfunction, NT-proBNP, because I refer to the case of sudden cardiac death, they can drop dead even though they have only few symptoms. And the third question is ventricular dilatation and ejection fraction. The inclusion criterion where we have the data is based on ejection fraction. Yeah, so you might believe it or not. So that is a Paradigm HF trial, but also the combined analysis of Paradigm and Paragon. So down to an ejection fraction of 55. So the guideline said 50, so 45. The people benefit. And I make no distinction between the dilatation of the left ventricle and the ejection fraction. But the inclusion to start the study was always ejection fraction, and nobody did it with a normal ejection fraction and diastolic dilatation. The question is of whether that is an overloaded ventricle, volume overload, maybe because he has aortic incompetence or maybe some mitral valve.
Yeah, thanks, Dr. Ba. Another question is use in a hypertensive patient with concentric left ventricular hypertrophy, or the patients who are having elevated pressures, you have already answered, but the hypertensive patient with the concentric left ventricular hypertrophy, its advantage over ARBs. A lot of doctors do say that if there is a hypertrophy, why should we go for ARNI when there are other drugs which also reverse the cardiac remodeling? So benefit over there.
Yeah, the benefit there, it was never approved as an antihypertensive drug in Europe because we have enough other drugs to do that. But now in HFpEF, when the ejection fraction is slightly reduced, I go for the ARNI instead of a calcium antagonist, definitely. although both have shown to reduce ventricular hypertrophy. I think it is even in China, it is approved for resistant hypertension. When a patient has a resistant hypertension, you have no other chance. Of course, aldosterone you might have in, that is also according to the TopGet study. But still, if the blood pressure is still high, of course, I think and I believe that indeed sacubitril valsartan is another option.
Doctor, just a last question. There is also a study where they have looked into the aortic stiffness, which was reduced with ARNI therapy.
Yeah.
So clinical significance of that, or the patient profile which may benefit with this mechanistic role of ARNI in reducing the aortic stiffness.
Aortic stiffness and also the interaction, the myocardial vascular interaction, the atrioventricular coupling, you might call it, is very important. Heart failure with preserved ejection fraction. I don't think that the improvement of stiffness is simply maybe a cause or a subsequent phenomenon of reducing blood pressure. Yeah. You can see also similar things with AT1 blockers, which have been based on that started or have been attempted to for the treatment of HFpEF. I think it shows that the drug is working. Whether the stiffness has a direct causal relationship to an improvement of outcome, I'm not sure. Yeah, these are interesting studies to look at mechanistic points, but it's not really something which is a lone standing phenomenon. But it's very interesting to look at and follow up on that.
So just last comment from our side, Dr. Baum, from your presentation, one of the sequence in which you have mentioned the drugs introduction, although all the 4 drugs have to be introduced together in the doses that you have suggested. But if the doctors are going for a sequential therapy, so our understanding is that the beta blockers will be in the first class, followed by ARNI, and then SGLT2 inhibitors and MRAs. Is that sequence right from our understanding?
Nicht. Punkt. Das sollten wir besprechen.
Dr. Vidya, you can take over.
Thank you so much, everyone. Dr. Puneet Verma, do you have any last few questions for our panel?
No, it's perfectly fine. I think an important point made by Dr. Baum is that please don't look at even in functional class, NYHA class 1, treatment of heart failure should be as aggressive as in the higher classes as well. Never take NYHA class 1 as an easy lying down condition. It is a sinister condition, and the prognosis, obviously, as he said, that these patients can have a very high incidence of sudden cardiac death, and therefore all top rung therapies, whether it's imparting the 4 pillars or 5 pillars of the armamentarium, it should be absolutely justified even in class 1. I hope I got that right, Dr. Baum.
Agree.
Thank you so much, all the esteemed panel of doctors. I would like to invite Mr. Archis, who is commercial head for Maximus, and Mr. Neeraj, Dr. Neeraj, who is head of marketing for Maximus, for closing remarks and vote of thanks.
Yeah, so thanks, and not taking more time because I know Dr. Baum has to catch a train for the next destination. Correct. So it was truly wonderful, to have just one comment I would like to tell. See how the content and how, having eminent speakers matter. Like people have perception that virtual programs are not very successful, but I would like to tell all the esteemed speakers that we have close to 1,000 plus specialists attending the program right now. And it's thanks to, your presence, Dr. Chakravarti, Dr. Baum, Dr. Jabir, Dr. Puneet, Dr. Sudhir. I think it still underlines the belief that when you have the eminent speakers like you on a weekend, Saturday evening, also 1,000 specialists can give their dedicated time. That's something wonderful. So we sincerely thank you, and the journey for heart failure will be strengthened by more such initiatives. We look forward for hand holding by all of you. in that. I would like to invite and welcome Dr. Baum also to India. It's a beautiful country. Once again, you can have a visit, right? And have a safe journey and have a nice weekend to all of you. Thank you very much.
Thank you very much. Thank you. Bye-bye.
Thank you.
Thanks. Bye-bye.
Hello. Hello.
Yeah, Brijesh.
Yeah, can I end the session?
You end the
Yes.
session.